7:01, and I think it is time to start the OEB meeting for September. Now, you're hearing from me, your trustee vice chair, because it's I don't think JJ is available today. And so
Yes.
as the vice chair, I get to roll in and chair the next this afternoon's meeting. If you see me nodding off, it is because I just chaired 3 hours of CIAO, and that's just the way it is sometimes. So with that, I'm going to call to order the September 5th, 2023 meeting of the Oregon Educators Benefit Board. We are meeting virtually. With that, I'm going to welcome everyone, and we will call roll. So I'll go through that. Jeff.
Hello, here.
Hi there. Great. Michelle.
Here.
Great. Enrique.
Here, sir.
Bill.
Here.
Bonnie. Bonnie, I saw your name, so I think you're I'll circle back. Susan Miller.
Present.
Susan Enrique Smith.
Present.
Bob.
Here.
Robert Young. And JJ. Not here. Okay, so Bonnie, I see your name, but I didn't hear your voice. Question. Okay. I think you're here. I see you're lifting up your hand and you are present. Great. Thank you. Okay. First item of business is the approval of the September 5th, I'm sorry, of the June, let me get the date, all right. The June board meeting, June the 6th. You had it in your packet. Were there any comments or concerns? Otherwise, I will request a motion to approve.
Move to approve. This is Susan.
Thank you, Susan. A second.
Bill seconds.
Thank you, Bill. All in favor say, Rose, do I have to take a roll for approving the minutes of the minutes?
Not if everybody's unanimous, you don't.
Okay, fine. Okay, all in favor say aye.
Aye.
Opposed? No opposed, so minutes are approved. Okay, with that, we start with one of the things we have to do, which is to look at rules, and we have April talking to us about definition of HRA. So April, are you there?
I am. Can everybody hear me okay?
Yes.
I sure
Yes.
can.
Okay, because it's not showing that this is working. So good afternoon, everybody. Thank you for giving me some time on your agenda today. You know, if you see my name or my face, that I'm going to be asking you for something. Last time you saw me was in April at your April 4th board meeting, where I brought to you a small change to our definition of health reimbursement arrangement, or HRA, that was brought to us kind of over the past year from some entities. And you all approved us to go through the rulemaking process, permanent rulemaking process, and they were filed as temporary. While we did that, we held our public rules hearing in June, and we were open for public comment. We didn't receive any formal public comment. We did have some attendees to our rules hearing, which was so exciting for me. I love it when people are engaged, and no formal comments, but we had a good conversation. The majority of the questions that came in were really geared towards the HRA vendor. But at any rate, we went through the permanent rulemaking process, and now we're back here requesting to file permanent and then repeal the temporary rule that we have in place. Any questions?
April, would you like a motion to approve these changes for a permanent change in the rules?
Yes, please.
So moved, Jeff here.
Thank you,
Bill
Jeff.
seconds.
A second. Bill
Bill seconds.
second. Thank you. If there aren't any other motions, we'll go through the roll vote for this. Jeff,
Aye.
Michelle,
Aye.
Enrique,
Aye.
Bill,
Aye.
Bonnie, Bonnie, we still don't have your, okay, I see it. You raised your hand. Yes, thank you. Susan Miller,
Aye.
Susan Ricky Smith,
Aye.
Bob,
Aye.
and Robert. Have you joined us?
I have, aye.
Great. Okay, so the motion approves. April, you've done it again. I think your track record is 100%.
I think so. Thank you so much for your time. I really appreciate it.
Okay, on to the next agenda, which is talking about the upcoming 23-24 CL work plan, an overview, and how it achieves board goals. And it says Mercer Consultants. Who is going to introduce this for us?
Hi, Tom. This is Kirsten. I'm Mercer Consultants for this
Okay.
one.
Great. Okay,
Yeah.
thank you. All right,
Thank
you're
you.
on.
Wonderful. Thanks. And hi, everybody. It's great to see you again. We're really looking forward to another board season with you and getting to work with you in person again. For the CIO discussion, I know, Tom, you're going to touch on some of the strategy items as well during your CIO update in a little bit. So I really didn't want to steal your thunder. So I think what I'll do is maybe stay a little high level on the strategy part of it, and then talk about the agenda and a little bit about how today fit in with that and what you, the board, can expect over the next few months from CIO. And it really comes down to, what's driving all of our work in CIO is the goals of the OEBB board, and we all work together. You guys set goals in December of last year during our retreat, and we'll have an opportunity to recommit or refresh those this year. But what we're working with now are these goals. We have 4 of them, and I really love them because they're all unique and yet they work together. We have this shift left strategy, which says, how can we, through our policy and programs and the adoption of new medical technology and options that come down our path, how can we catch and treat chronic disease earlier? We have a goal of providing high quality, efficient care, efficient meaning the cost is reasonable and yet the quality is high. How can we provide high quality, efficient care while also keeping the member first and center, and making sure we have a good member experience? We have a 3.4% budget cap. So each year we need to keep our renewal increase to within 3.4%. And then we also have this overarching goal as well of providing education to our members to make sure that they understand the full suite of programs and options that are available to them so they can take advantage of all of the hard work we do and making tools available and making resources accessible. They know where they are and how to access them and how to use them and what their benefits are. So if we go to the next slide, CIO really fits in with that, because if we think about the elements of a health plan, we have the operational elements of a health plan: calling customer service, having claims be paid on time, timely answering of phone calls and returning of questions. We have the financial aspects of the plan, how much is the premium, what are the cost sharing elements, co-pays and co-insurance. But then, of course, because we're talking about health insurance, we have this huge aspect, which is what are the clinical programs within the health plan? Are we meeting our members where they're at? Are we identifying what conditions they're suffering from and bringing them solutions to help manage their conditions, and also, of course, prevent conditions from developing in the first place? And so we worked with the CIAO committee to really think about a framework for CIAO. And this is how we articulate, how we serve the OEBB board and the board's mission of achieving its goals. And it's this idea of high level of clinical oversight and then also clinical strategy. So within clinical oversight, we have this role of assessing the value, and we mean value in a couple senses. We mean the clinical value of the program, how effective is it at improving member health? Also the financial value of the program as well. Are we achieving member health at a reasonable cost, especially when we look at the long term? And then we have an oversight element as well, which is once we vet these programs ahead of time to understand, do they fit in with our strategy? Do they look like they'll provide value? We need to monitor them over time to make sure that they're delivering on their promises. And then the CIAO committee really also has a clinical strategy role as well, which is, when the board comes to making its renewal strategy, and we're going to be working with you on that in December, we need to have some clinical program ideas up for consideration. And that's really the second major role of the CIAO committee, is to look at OEBB's data and what's impacting its members, and what are the activity of members, and where are we spending the majority of our money, and come up with some clinical program recommendations for the CIAO committee or for the board to consider. Rose, next slide. So over the summer, the CIAO committee was busy with 2 summer work groups, and we were really pleased to have some members of the PEP board involved with that as well. The CIAO committee did a deep dive, and you're going to hear more about this from Dr. Chuang and Dr. Siltabo as well. Did a deep dive into GLP-1 drugs. So that's the new class of weight loss drugs that you're hearing about in the media. And we also looked at doula services. A doula is a licensed support person who helps birthing parents before and after the delivery, and delivers better outcomes both for the parent and also for the child. So we looked at the doula benefit, and you're going to hear an update on that. And then we also, in preparation for the CIAO meeting this morning, requested some reporting ahead of time from the carriers on programs. Some of them have been in place for a while, and some of them are newer. Some emerging results on how those programs are running. What's our engagement level? Do we have any early clinical outcomes? And those were the Wellness Advisor and Wellness Space grants from Moda Health and Kaiser Permanente. We talked about health coaching. We talked about the diabetes prevention programs through Kaiser and Moda. And then we also requested reports and reviewed those this morning in CIAO related to the care management programs Moda has in place, Behavioral Health 360, PCP 360, and Moda 360 as well. And then we'll be kicking off as part of our cardiometabolic treatment work, that's diabetes and related conditions like overweight and obesity, that we kicked off with you last spring. We'll be doing a deep dive into our weight loss treatment options this fall as well. And then Rose, if we go forward 1 slide, please. So at this morning's meeting, we performed some oversight and some assessment in looking at the wellness and pre-D programs and the care management programs as well. And then you're going to hear about those from Tom. Also in September, we're going to kick off clinical metrics review. So those are the quality measures and HEDIS scores. We'll be requesting those reports and collaborating with carriers on any proposed changes for next year. And then we've also solicited ahead of time and have actually received from both carriers their clinical program ideas for the next renewal. And it may seem early. I anticipate the renewal is going to be on us faster than we expect, and we did just really learn with you all last year. I think as healthcare gets more advanced and the programs we're considering get more complicated, we just need more time to be able to do, you know, a full value assessment of those. So we're starting a little bit earlier, and CIAO is going to do some background work with those before we bring a proposal to you all, the board, in December. CIAO won't have a meeting in October because that's going to be devoted to the board retreat. And then if you advance one slide, Rose, please. Yeah, actually one more. In November, the big November agenda item is for the CIAO committee to take the board's direction from October, the October board retreat, where the board will be looking at cost and utilization data with Dr. Chuang and Sarah Drake and deciding on areas that it would like the CIAO committee to dig into deeper as part of potentially the next renewal cycle. So the CIAO committee will bring that work back the next level down in November and talk about that. And then we're also going to be looking at our current weight loss options and just assessing the market and doing our due diligence on that piece as well. And it's all working towards a December agenda, which is if we achieve all of our CIAO goals, then by December we should be in a good position to have reviewed the carriers' clinical program recommendations and also compiled some of our own and bring to you, the board, some clinical recommendations for you to consider for the renewal. We also have some member benefit requests that we've received, and we'll definitely want to spend some time talking about those. It's tentatively scheduled for December as well. And you'll hear more about the work this morning and also over this summer from Dr. Chuang and also Dr. Siltvo. Any questions? Otherwise, Tom, back to you.
Thank you very much, Kirsten. The only additional thing that someone raised it today at CIAO meeting. The board was quite insightful last December when it talked about trying to shift left. And that is the big, bold, audacious thing. Part of it, though, as probably more important, is to delay or the movement right. The catch is with a lot of medical conditions over time, they can get worse. They can progress and complications can develop. So as important as trying to shift left, which as the example is someone who has prediabetes to get him or her into a normal metabolic state, or someone, let's say, even with early diabetes, to move them to the left to the pre-diabetic state. A lot of it also, as important and maybe even more important, is to prevent people shifting right. You have the diagnosis of hypertension, it's going to be with you. What you need to control it so that you don't, things don't get worse and you don't have the complications. True with so many other complex conditions that people have. So it's shifting left and trying to keep from shifting to the right. That's kind of our motto. And I think Kirsten very eloquently outlined where we're going. For those of you who've been on the board for a while, you would look at this and saying, well, this is stuff we usually talk about in January and February. And as we ran into last year, last plan year, as we were trying to think about opportunities, we really didn't have the time to answer the questions that were out there, and they were premature. So it shows the complexity of the work that we're doing. That CIAO, also, it's been true with the innovation work group. Many of the issues that that group has worked with it's complex enough that it becomes a multi-year process. But again, we'll keep working on it. Any other questions about CIAO and the direction that the overall direction that we're going. We will, and Ali will talk about this, I think, later, but we are very interested in adding additional people to that group. So as board members, if this work sounds interesting to you, we would love to have you join us for the Tuesday morning. Enrique joined us as a guest today, and I really appreciated that. And hopefully it was worth your while to join in, Enrique. But so we will be looking for additional people to participate in CIAO. So I guess that's it for the update. We'll now move on to CIAO summer update. This is where we dealt with the doula coverage and weight loss drug coverage. And I'm going to provide the introduction to this, and then, but our subject matter expert who's been working through the process has been Dr. Ian Chuang, and he will carry the bulk of the load. So next slide. So you heard this. What we've had our consultants, our OEB and PEB staff, and our health plans have had representatives working July and August, trying to work through the complicated details of these two issues. So what we're going to be presenting is what's been happening with that and next steps. Next slide. And again, there we go. Okay, so so these two research groups have been working. They've been meeting twice monthly. There's been a leadership group that is making sure that they are moving forward and understanding where things are going and giving recommendations. And we are then the important thing is to see all the participants. But besides Kaiser Permanente and MODA, Providence Plan has been participating, because this is we're looking at a joint OEB-PEB decision making in this. So actually the presentation that you're hearing today, I will be assisting Dr. Chuang on in 2 weeks and presenting this same information to the PEB board. Next slide. So this shows you what the charges were. For the doula group was drafting proposed doula coverage policy options, addressing the implementation challenges, and then describing how we would understand effectiveness, how we would measure that. The weight loss drug research group is drafting proposals around that group of drugs called GLP-1 drugs. And for those of you who ever watch television, it is this class of drugs. Example is Ozempic, and it actually is only written for or approved for diabetes, but the same drug in a higher dose is used for weight loss. An interesting sidelight: the company that makes this, Novartis, which is centered in Denmark, the company's net worth, or its market capitalization, is greater than the domestic product of the country of Denmark right now. These drugs are so hot. Jeff, you've raised your hand.
Yeah, I'm just curious, this drug, I guess, Golo, is being advertised profusely. And does that fit into this classification?
I don't think at all. That's a supplement. It's not an FDA approved drug.
Yeah, thank you.
That I know of. Yeah. And there was another hand. Maybe not. Okay, so I'll continue on. The idea is to, we're looking at whether or not there should be coverage options for these drugs for the management of obesity, and understanding how it fits into the spectrum of cardiometabolic syndrome, which is associated with multiple diseases, particularly cardiovascular and the issues of diabetes. There also then is, besides just the drug, are there lifestyle or behavioral interventions that are necessary for a long-term treatment of obesity to be effective? So, and then it's a question, how do you measure it? Next slide. So we're going to first focus on doula, and doula coverage is interesting. Doulas are assistants who have training, who offer support for women, I should say pregnant people, who are going through pregnancy, and they provide prenatal, perinatal, that's around the time of birth, and postpartum, after the period of time after giving birth, and there's various assistants. Now, the interesting combination here is that there are multiple reasons why we would want to cover this. One, there's a suggestion, there's ideas that it helps reduce morbidity and mortality. So in that bottom column, you'll see that already Black women are, and this is across economic levels, are more likely to experience severe outcome, either significant injury or death. So there's, this isn't just a medical issue, this is a health equity issue, and one that actually will be getting an update from the Health Equity Committee, where they actually looked at doula coverage. Next slide. So, and I'm going to now pass this on to Dr. Chuang, and he's going to take us through some of the specific data that the work group has been looking at. Ian, you're on.
Thank you, Tom. So let me just finish off this slide here by commenting on, the recommendation from the Oregon Maternal Mortality and Morbidity Review Committee that made recommendations as follows earlier this year, and this carried forward into the OHP. So healthcare systems employ doulas, can provide culturally sensitive and language relevant support for specific populations of women in pregnancy, where there is disparity and potential risk of adverse outcomes. Integrating the doulas into client care up to 1 year after pregnancy, providing state level incentives to healthcare facilities to hire doula. The important factor here is making sure that the care process is seamless and integrated for that mother and newborn, because ultimately the delivery is going to be by a medical professional, and we want the doula to be aligned and integrated into that process so the care does, and the recommendations and guidance for care are integrated. And the last point that was made recommendation-wise was to maintain a directory or statewide online site so that there is transparency and accessibility to these doulas with different backgrounds, different culture, different language skills, and capabilities, so we can find the right doula, qualified doula to the individual that is seeking the care. So this was the recommendation that carried forward and is currently being supported. Next slide. So within the context of OEBB, the research group kind of noted these 4 factors and considerations as we move forward. So there's clarity and good bodies of research and evidence that, the doula services do reduce some of the complications of pregnancy, specifically C-sections and some of the other complications through a number of means. One is just to support the disparity in the mothers, pregnant mothers, to address their needs in a culturally sensitive and appropriate way that helps them be informed, be literate about their healthcare needs, and to make informed decisions. But it's also to increase the number of prenatal visits to help with the advancement of health literacy and informed decision making. We know that through that, the doulas do show reduced preterm deliveries, increased delivery satisfaction, etc., specifically for those subgroups, disparity, individuals where there's just known adverse outcomes that occur at higher rates. The reality of network adequacy was also sort of front and center. There is no limitations in terms of the doula network, and there's multiple factors. There's there's a certification that's required to ensure that there's qualified individuals identifying themselves as doulas, and then making those doulas available through a carrier is also key. There are community-based organizations that sort of are trying to support this and having come up with pre-built networks to serve the needs of a diverse community to sort of advance the service forward. So those are things that just have to be factored in as we contemplate this. From a benefit design, ideally, doula service should be made available and accessed as soon as the pregnant mother is informed of her pregnancy. This can be slow for various reasons, that access to the first OB visit or delays in doing that confirmation pregnancy test. Many reasons, but obviously getting them connected to the doula is to maximize the value of the service in aiding that maternal mother in her care. There's also good research that shows that the value of the doula is also post-delivery, after birth, for assisting with some of the health needs that are still significant after delivery and up to a period of 1 year. So again, this is supported by good literature and studies for validating that. So as you can see, the potential challenges that were identified by this research group kind of center around these two things. How do we get this service considered, integrated, and accepted within the existing plan? The awareness is important. So the awareness, education, and connecting those who can benefit the most from doula to having access to these services. That being said, the adequacy of available doulas within Oregon may be a limiting factor. The experience and learning from the doula services coverage currently with OHP will be sort of a lesson learned, and that knowledge can be applied forward as OEB and PEB considers that. But it's also the potential conflict in the sense that if there is a limitation in the network adequacy, is there potential for compounding the disparity because of competing members for the same limited doula resource. So lots to consider as we proceed forward. Next slide. So despite the benefits nationally, the adoption and availability of doulas is not very uniform and is somewhat still limited. Our survey found that only about 23%, less than a quarter of employers with 500 employees or more actually had coverages for doula, midwives, birth center, or other alternatives to improve birthing outcomes. So that's a bigger survey question, but doula was obviously one key component of advancing and providing the flexibility to meet the diverse needs of pregnancy care. By geography, a couple of examples that I've pulled up here just to give some insights. Rhode Island is requiring doula coverage in their fully insured private insurance plans as well as Medicaid. And their program is structured in sense in that it's $1,500 for doula services, or up to 1,500, and each plan is defining its coverage and provides a reimbursement form for the member to submit. So this is one where sort of the member has to provide the upfront payment, and then they're submitting for reimbursement. So that's one model. Providence Swedish Hospital in Seattle is offering doula programs to their patients with a fee base from $800 for an apprentice to $1,200 to $3,000 for more experienced doulas. And the hospital is also offering postpartum doulas as part of their service offering, a bereavement doula, and then specific programs tailored to the Black and African American clients and doulas, where we know that there's this differences in outcomes, negative outcomes for this subgroup. So those are two examples of programs that are in place. And then obviously Oregon OHP has their program that's new, and we're looking to learn from that as that takes shape and proceeds forward. Next slide. So just to comment on the OHP, my current understanding is it's currently covering services similarly up to 1,500 for pregnancy, and inclusive in that are 2 prenatal visits, 2 postpartum or after birth services, and then the support of the mother during the delivery itself, during the through the delivery process. So that is the current doula service offering through OHP. The doulas that are eligible to provide those cares through OHP have to complete a certification and registration process. So these are not licensed medical professionals. However, there is a certification to ensure that there's a minimum level of knowledge and skills to be a certified doula. Upon completion of the OHA approved curriculum program, they can enroll in the state registry that allows basically the issuing of an MPI and the ability to enroll in the Medicaid program as a provider and be made available through their members. So currently, approximately about 230 registered doulas are part of the OHP plan presently. So just some point of references of a program that's in place in Oregon, and the factors that we have to consider and weigh as we consider it for OEB and PED potentially. Next slide.
Ian, NPI, yes. National Provider Identifier or something?
Yes.
Yeah. Okay.
So that's a universal identifier that recognizes them as a provider and helps them also get reimbursed through plans.
Yeah. And Susan Miller, I saw a hand go up.
Thank you. I was just curious if there were more doulas that are not registered with the Oregon Health Plan other than the 230, or is that 230 that are registered in the state at all?
So those are the 230 last count those are registered within OHP. Are there more? Probably. I don't have statistics. I don't have a number, but I got to believe that it's a subset of those that are choosing to register, well, get certified, register, and be a provider for the OHP population.
Susan, I think the people can call themselves doulas, and the because there are multiple different trainings and programs that lead to some certificate. So the reason that and I'm guessing the reason that the state put together this curriculum that people had to go through to be put on the list was to address that issue of does the what we're going to be paying for this service, they have to have at least a certain amount of training. So I think because there aren't national organizations that cover all doulas, as as a physician, I took national boards, that every other doctor in training took to be able to get the license. There isn't anything like that in for doulas. That was the reason that the number, and so I'm not surprised that they required that, and it's probably reasonable that OEB and PEB look at that same type of certification / registration to avoid the debate around what training people had to become doulas. I think we'd have to address the issue if we found that we were excluding all the people who supported a certain population at risk. It would be an equity issue that we need to explore. The good news is the Oregon Health Plan is looking at it ahead of time and hopefully will identify major gaps. Were there I saw some more hands pop up. I'm not sure if people have, no, I don't think there are any at this point. Okay. Sorry, Ian, you're back on.
No, happy to take those questions as they come up. So to conclude this section, the next step and where we are with the research group was a request back to the carriers to start to sort of do pricing based on some of the parameters I covered, right? The number of pre-birth visits, plus the delivery care, and then the post-delivery services as well. What those cost implications look like. Obviously, based on that, we would have to have that discussion and proceed from there. But just to get some parameters around this from our carrier partners is the next step. Any questions about that? Okay. The second,
my only additional point on this is that we are so lucky that both of our health plans are part of OHP, so they have already been working on this issue, and I assume Providence also is working on it as they participate with OHP also.
Okay, let's move on to the next big research group topic. And it's top of everybody's mind because thanks to social media and everything else, everybody is aware of these GLP-1 medications. So just to level set, these GLP-1 medications are not new. As Tom alluded to, these medications have been available and originally used for treating high-risk type 2 diabetes. However, we're going to talk about the GLP coverage in what I call sort of diabesity, because it is the overlap of obesity with a number of other conditions, the main one being diabesity, for two reasons. One, medically, physiologically, obesity is tied to every one of these other conditions, either in the sense that it can contribute or lead to these other chronic conditions, or obesity itself complicates the treatment and how care and delivery care can be addressed for any of these other problems. So basically, obesity complicates any one of these conditions. The dotted line circles something that is understood as cardiometabolic syndrome, meaning these conditions are so interrelated that they often appear together in clusters. And again, one of the large primary culprit is obesity. So that's why this is front and center. And as we think about always shifting to the left, this is an example of, doing that aggressively is potentially reducing the progression, to Tom's point, keeping it from moving to the right and the onset of many of these other chronic conditions that are more costly and more impactful to the detriment of somebody's health and well-being. So a couple of key points. Obesity is not just a lifestyle condition. It is accepted and understood as a disease. And like any other chronic disease, there's aspects of treating it to improve it, but when the severity is significant, the medical community, the physicians, we have to be aggressive in reducing that risk and that severity quickly. So that's where the medications, something like a GLP, where it's very effective, comes into play. And that's why this is being discussed. So even though it's about GLP-1 coverage, ultimately it's about how do we want to provide services and treatment options, because at the end of the day, it's the physician and the patient making these decisions to make this an option for aggressively treating a subset of this group of individuals with high risk. Next slide. So for this research group, 6 instead of just 4 sort of key areas rose to the top for consideration. One is, again, recognizing obesity is a complex multifactorial. Yes, improvement in eating and lifestyle choices can have an impact, but for many individuals, that alone is not sufficient because there's potentially genetic factors. There's social economic factors that make it hard for certain individuals to even try to do things in their lifestyle and make better choices for themselves. And that includes, those in disadvantaged social economic areas, for example. But we do know that as a metabolic process, there are potentially the need for aggressive treatment, and that can be medications or it can be bariatric surgery as well. So we have to view it as a chronic disease, not just the byproduct of poor lifestyle choices. The second key point is the approach for a benefit to cover GLP. We have to weigh options that are available to us. One, it can be based on defining a coverage by certain parameters. So based on the recommended treatment guidelines, the GLP-1s are indicated for those with high risk factors associated with obesity. So no one in the medical community recommended that GLP-1 should be used for everybody with any level of severity of obesity. But that can be defined within a plan design. So that can be explicitly defined, and that basically excludes those that are approaching GLPs for cosmetic reasons, convenience, or other factors that are not medically appropriate or necessary. The alternative option is to think of it as a medical criteria-based prior authorization. The discussion and the feedback raised the concern that when we do it this way, that when it's based on a prior authorization, it's some criteria at the time of the prescription, and that may lead to an appeals and other review process that at some level ends up being approved anyways, because because the current guideline is more open in terms of what is defined as eligible patients with obesity that can be beneficial for GLP treatment. So this is a plan design option that has to be weighed and considered, and this is on the radar. One other consideration, the prescribing implications of GLP. Again, the GLP right now as a medication is being prescribed. It is hitting your plan cost, but it's due to the type 2 diabetes. But like my diagram previously illustrated, obesity leads to type 2 diabetes in many cases. So in a way, as we consider and contemplate the pros and cons of providing aggressive treatment options for obesity, we also need to weigh the reality that if some of these obesity high risk is not reduced, they will progress to type 2 diabetes, and they will end up potentially being on the GLP-1 medications when they already have type 2 diabetes, when they have type 2 diabetes and other comorbidity or risk factors. So that's why understanding this continuum is important, because at the end of the day, it's not about restricting GLP-1s, it's about when and how do we want to optimize the care of these high-risk group. The GLP-1 prescriptions in parallel with intensive lifestyle intervention, that is based on the recommended treatment guidelines. So none of the recommendations for GLP-1 coverage was in isolation. There was always a recognition that the medication can be highly effective, but bottom line is we still need to optimize our internal metabolism through optimal choices and lifestyle behaviors that help to optimize the outcomes. Step therapy as a clinical approach versus risk-based therapy. So this other topic was brought out as a consideration in the sense that oftentimes, and guideline does support that for certain individuals, a step therapy approach makes sense. A step therapy just means we try lower cost, although the cost is not the primary driver, but typically it's sort of less aggressive approaches to addressing a condition or a problem. That's true for hypertension, it's true for cholesterol, it's also true for diabetes and also for obesity. So that means that we try some simple things, let the individuals do as much as they can with that approach before we keep escalating to more aggressive treatment options. The alternative is basically risk stratifying that individual, which makes sense for those with highest risk, right? So if some folks are so high risk that a step approach is not going to be effective because their class of severity of obesity is so significant, or they're having so many complications already that the time it would take to do step therapy would be lost opportunity. That disease process is ongoing. So we're wasting time trying to do step therapy as opposed to using a medication that we know will be effective, quickly bringing them down, and then work on the more nuanced self-care and other treatment options as a result. So obviously implications to how the plan design would be structured and worth ongoing discussion. The last point that was raised was around these aggressive treatment options. Bariatric surgery is covered and available, and it is indicated for a same set of individuals that could also be considered for GLP-1s. So in a way, would the coverage of GLP-1 provide treatment options for those that are the highest risk category, for those that may be adverse, or for those that the bariatric surgery may be an added risk that isn't appropriate. The GLP-1s would give them that alternative treatment options to address what is already an established high-risk scenario. So these 6 are very hefty factors to consider and weigh as we discuss and proceed with the GLP consideration for obesity treatment. Let me pause there because that was a lot of stuff, but happy to dive in or discuss further. Okay, next slide. Oh, got a hand.
There's the question.
Yes.
I'm just curious how obesity is diagnosed, because I know that the BMI calculation has kind of come under fire
Scrutiny.
in recent years.
Yes. The BMI is a crude instrument, and it will be oversensitive and undersensitive for certain populations. Typically, as a physician, we weigh that and we look at the individual, right? So there's other factors that we consider. For example, central obesity is a bigger risk factor. So if you're higher in weight, but it's because of muscle mass, that's a different consideration than central obesity as a primary source of your obesity. And also different ethnicity. We have a different threshold because of just overall average weight tends to be lower, for example, in the Asian population. So those are things that, as a physician, we are modulating the factor. But as a broad sort of instrument, the BMI classification is sort of that consistent vocabulary that we use. That's why, you know, these treatment options are never sort of blanket statement. They should be discussed, and there's pros and cons. That should be discussed between the patient and the physician, ultimately making those recommendations for treatment.
Thank you.
Jeff.
2 questions. Well, are some of these drugs lifetime drugs?
So going in, assume that GLP-1s will be lifetime if nothing else is changing, right? Which makes sense. The physiology that's driving the development of obesity is ongoing, and the only thing we introduced was this GLP-1 medications, then yes, the risk is you remove the medication, that physiology is still there, and it will revert back. That's why the treatment guidelines in this bottom left square alludes to the fact that we should prescribe and use GLP-1s in conjunction with concurrent intensive lifestyle intervention. So and our experience for weight loss is still limited, but early indications are that a subgroup of individuals, when their intensive lifestyle does become muscle memory, they're making the appropriate changes, they're optimizing some of their choices around nutrition, physical activity, they can sustain themselves on that improved lower weight with either a reduction in the GLP medications, a switch to a lower cost one, or potentially even discontinuing. So some can come off, but that requires them to basically, step in and sustain those improvements through those choices and behavior.
My second question is, I may not say this really well, but you're alluding to different makeups of people. So how do we navigate a formulary in this area?
Yes, and those are all the various dials and levers that will impact and have to be weighted as we make a decision on inclusion and coverage, and they will have both clinical and financial implications potentially. So, there's many levels of equity. We know that obesity and type 2 diabetes is not evenly distributed across a diverse population. We know there's disparity by socioeconomic and ethnic backgrounds. But we also know that the treatment isn't also uniformly optimized for each of those groups as well. Some of it is because of the cost of the treatment options and their potential out-of-pocket. But some of it can be also intrinsic treatment biases that the professional medical community brings to the table unintentionally, but it does have impact. So all those things become an influencing factor, especially for something that's so impactful but potentially costly.
We had the same debate when we added bariatric surgery, in that we ended up, the recommendations at the time were coverage for people with BMIs 40 or greater, or I think it was 35 with extenuating, complicating situations. So that was, there's ways to do it as compared to just saying on the formulary, not on the formulary. But again, those are all the details that would need to be worked out. And it raises the issue of if we are using BMI, the issue around, is BMI the right tool? BMI is very helpful in terms of looking at large groups, and particularly watching over time. It shows trends that are really, very important. But it will be usually when someone has a BMI of 40, there's not much question that there is significant obesity. It's at the lower ranges where there's, some people who would be at maybe 28, 29 who are in the metabolic syndrome, cardiometabolic syndrome land, while people at 32 aren't.
Great questions, thank you. Next slide. So in the next slide, I try to sort of illustrate and put in context kind of the spectrum and where we can land in our recommendation to from CL to OEB. And it's on the two ends, it's basically not covering at all versus covering, but putting no optimization to it, which becomes potentially an unfettered sort of consumer demand and all the influences from social media. So I would say that extreme, this is not a place where we want to shift to the left, but some land somewhere in between in the middle, where it is about optimizing and ultimately impacting those individuals that would benefit the most based on clinical joint decision making between the physician and the patient, but having this as an option, but not on its own. As we talked previously in the CL update meeting, there's already programs in place, right? So we know that there's other factors that have to be in place, taken advantage of. It is kind of how we choose to conduct ourselves in terms of the food we choose, the level of physical activity, and it is our environment, both at work and at home, to optimize it. Sleep, stress, all those things play a role. So in addition to thinking about covering this medication and thinking of it as a return on investment mindset, elevating it to thinking about this as a return on the individual and helping that individual have the most resources and available services to help them achieve their best health state around a cardiometabolic condition. And I say it that way because it's more than just obesity. It's those other risk factors that we're trying to mitigate. Shift to the left means keeping those conditions from coming. Next slide. So I think in terms of the ROI, it's important for us to weigh because the cost is significant. I put this slide here just to raise the consideration and make it apparent for our consideration that as we make plan decisions, we have that 3.4 from a plan year to plan year. The reality is, if you look at the type 2 diabetes, that is the strongest risk for obesity. As soon as a 5-year time frame, it's a 4.2 times higher risk of developing type 2 diabetes from obesity. But it is still 5 years, right? It's a window of 5 years that a subgroup of those with obesity will end up developing type 2 diabetes as soon as 5 years. But we're having to make decisions on a year to year. So that's something to consider. There's these other severe chronic conditions that are equally important, but they are of a lower risk multiple. Diabetes is the highest risk multiple at 4.2 times the risk. The economic burden, we can quantify that, but that's over time, total economic burden. So it's a larger, longer metric. It's a type 2 that I really want to call out. Yes, question, comment?
Yes, thank you. So we have discussed this earlier. I like how Tom eloquently put the equity is an issue and the race and economics are part of some of the health components of our members across the OEB system. So I was wondering if, I was looking through the report, but I don't seem to see it. But I was wondering if you have a breakdown by race and how can we address this particular issues in that category as we're looking at how race and gender respond to specific sort of services like the doula, right? Black women tend to have higher mortality rate than white women and other racial groups. So I'm assuming this is the same thing for diabetes. So I was wondering if you have something or Kaiser Moda are working on something that we can speak to, like this is what we're doing or this is what we're thinking about. That'll be all. Thank you.
That has not been tackled or discussed explicitly within our research group. Kirsten, is there any plan to, or with the equity group, to start to dive into that more? Do you know, Kirsten?
This is Christy Ewing, and I'm happy to say I am. So after our break this morning, I think I do have a presentation on health equity, and we do have some of the work and research that our group has done regarding the doula and the GLP-1s that we'll be able to share some of that literature and data.
Thank you. And that GL is related to the diabetes and correct? Obesity.
So what we've done is, in conjunction with being part of the CIO2 groups, we've looked specifically right now at the doula coverage benefit and then also the GLP-1 treatments for obesity. And that's specifically what I have information on today. We certainly do also in our health equity work group look at some of those broader programs as well. The diabetes prevention program has been one of them that we've also looked at from a health equity viewpoint. So I'm happy to provide follow-up information on that to you as well.
Thank you.
So Enrique, see whether or not you're after that presentation at 2:35 answers your questions, and if not, let's circle back and see what else, what we want to add to the work group's efforts.
Thank you, Tom.
Okay,
Ian, you're on.
next slide, please. So just to provide further illustration, the shift left concept is very concrete for diabetes as well as obesity. Obviously, the diabetes, we're already covering GLP-1s, and those are to prevent and move to the left those with type 2 diabetes out of control or diabetes with complications. So the far right two blue boxes are the categories in which GLP-1 medications are currently in use. Obviously, we can move as many as we can towards the left. And this is one where if you're in a pre-diabetes, there's the opportunity to actually, prevent or slow down the progression to type 2 diabetes. We have to think of type 2 diabetes as the end result of cardiometabolic dysfunction, dysregulation that precedes it, starting with cardiovascular risk factors, which includes obesity, then into a cardiometabolic syndrome. So a lot of words here, but it's basically the ability to have individuals move from the right to the left in terms of their severity and their progression towards diabetes. The obesity has a similar course. Obviously, it's more severe to the right, but it's weight-based, and any step that we improve, and the improvement that's meaningful, we define as anything greater than 5%. The GLPs are able to achieve basically 10 to 15%. So they're well beyond just a minimum meaningful improvement. And that's why it's so impactful for somebody who's already severe obese. That is going to help them tremendously, both improving of their weight, but resetting their metabolic parameters and reducing some of their progression to those complications. Obviously, when we're closer down to overweight, we have the luxury of time. We could use lower severity or aggressive interventions, as well as lower cost interventions. So the interventions specifically, next slide, just for illustration of the overlap between bariatric surgery and GLP, based on the indications from treatment guidelines, it's basically this overlap with a small additional subgroup of obese population with one weight-related comorbidity that would fall out. So what I'm saying is everybody or anyone who's considering bariatric surgery by these clinical parameters would similarly fall into the consideration for GLP-1 as a treatment option. From broad studies, the current or recent past utilization rate differences are shown below. About, on average, 0.6 of the population end up proceeding with bariatric surgery. GLP-1 medications were originally around 3%. Some recent studies have shown that for some groups, it's gone up as high as 8%. So not surprisingly, as awareness increases and as the prescribing and coverage increases, that there's some increase in terms of the percentage being put on GLP-1s. So something to keep in mind. The last slide to illustrate is basically the overlapping recommended treatment options across the spectrum of BMI levels. So diet, physical activity, and behavioral therapy is across the board. It benefits everybody. Even if you're normal weight, we all have opportunities to improve a bit of our lifestyle choices and diet and physical activity. It is the cornerstone for all weight categories. So the programs that we have in place that we talked about in the CL update that we're trying to optimize and drive towards outcomes that matter, pertinent and relevant for diabetes as well as obesity. We already have surgery covered for those on the severe end of the obesity spectrum. What the GLP-1s will similarly add more treatment options, effective treatment options in this upper right corner of this continuum as well. There are lower cost medications that have been on the market. Our choices haven't been great. They were basically taking advantage of some of the side effects of mental health medications that we discovered had some weight benefit. But given that they're for mental health, there's other side effects and potentially some with dependency risk factors. So they were never the ideal treatment options, whereas the GLP-1s is specifically impacting those physiological parameters that lead to poor cardiometabolic health. So that's what we're trying to do here, is basically build out or consider whether we can make this matrix of treatment options more robust in line with the available treatment options currently. So the next slide is basically the current status and the ask for the carriers, which is to start to think about what it would look like in terms of relevant populations, as well as modeling some of the financial impacts of low versus high utilizations based on different parameters of targeted group, whether through a benefit limit design or through a medical PA prior authorization process. So we'll have a sense of sort of the funnel, the cost funnel, when each of these parameters are defined. Let me pause there. Questions, comments?
Sorry, Tom, you were on mute. Did you call my name?
I did.
Okay, good. Yeah, I just wanted to
I
mention,
did call your name. I'm sorry.
Oh, that's okay. I just wanted to mention, this is one of the kind of unintended consequences of that 3.4% in OEBB statutes, PEB statutes, that, making investments of significance, and I don't know what the cost estimates are going to be, but, really limit the board's ability to invest for, future outcomes. So I think it's just going to be important to continue the discussion. I know we'll discuss this at next month's retreat of, potential legislative approaches to issues like this, and on the PEB side to issues like the legislature coming and transferring money out of their stabilization fund. So I think that's in a broader discussion for both boards, but I think with the GLP investments, obviously there's a real significant return on investment to consider.
Yeah, and my only point, if indeed there is at 5 years, that the ROI starts changing, is we have the RSR, that's the reserve, the rate stabilization reserves. Is this the issue that we use that to get us over that, let's say, 5-year hump? I don't know. We still have we have a whole lot more work to do in terms of getting the numbers correct, but that would be one of the possibilities. It would be at least OEBB could consider it. I don't know if PEB has the same type of stabilization fund, or that's what you were just mentioning, Ali.
Yeah, exactly.
Okay.
PEB does have a stabilization fund, and most of their business is self-insured. So in good years, they've accumulated a high balance that the legislature has kind of used as a piggy bank to transfer and fund the general fund. So, yeah.
Yeah. Okay. Well, again, the next steps are as outlined, and the tough work is going to be making, is putting this up against the reality of the 3.4 and seeing what options there are in terms of investment. And that may be with going back to using the RSR, or potentially going to the legislature with a conversation. But we'll see how it plays. A tremendous amount of work that the plans, that Mercer, that OHA, OEBB staff have done, and I really appreciate it, and we really want to acknowledge this is something different. We've never done this, at least this is my 8th year on the board, and we've never done this to this degree, and it really will allow us to look at several very complex issues at a much greater depth, and hopefully make the right decision. Okay, thank you again. Thank you very much. That is I think the end of that conversation. We do have a brief CAO update. Kirsten, this was just, I think the closing parts is next steps is that we're going to be discussing it in November and December. So, and then CAO will come up with a recommendation in December. It'll give the board then a month to think about it. And the idea is that we'll vote in January about how to proceed. Correct?
Yep, that's correct. Mm-hmm.
Okay. All right. All right. On to CAO update. Okay. We kind of went over this Kirsten did a very nice job of outlining CAO's work plan and relationship to how we work on the goals established by the board. So you'll see that as we go through the issues that we talked about. Next slide. Back one. Yeah. I'm sorry. Next slide. Yeah. So let's hold on this one. Whatever program or intervention we have, these are all of the issues. There is number one is kind of defining the program. Number two is getting that information out and enrolling people into that program. The question is okay, what percentage of people do you actually engage with it? So you'll be hearing about pre-diabetes and our efforts at diabetes prevention. How are you able to get that information out? How many people who are at risk are you able to engage? Then it's, okay, you have them in the door. How many can go through it? In other words, how many actually complete the program? Let's say it's a 6-month health coaching episode. Okay, what percentage started it, finished the program? Then it's a question of, did you get the outcomes that you're hoping for? For pre-diabetes, much of the work is trying to get people to lose 5% of their body weight. So the question is, how of the 50 people who went through the program, what is the how many of them were able to get to that proven level of weight loss? And then it's a question of 2-5 years down the way, what are the numbers? You could look at all of the discussion around doula, around the GLP-1 weight loss drugs in each of these. One of the big questions that we just raised with the obesity medication is, okay, you've got to step number 5. of the people who've been using the medication for 12 months, you've got 80%, let's say 80% who've lost 7% of their body weight. Hallelujah. They stopped the medication. Check down 2 more years, what percentage has maintained that 7% weight loss. Those are the issues. And so everything that all the programs that we're going to be assessing, we're going to be trying to look at through these lenses. Next slide. Okay, so we looked at several programs. One of them was promoting wellness in schools. MODA has funded wellness advisors. They've used grants, and they have two wellness advisors that work with entities. They've also sponsored grants, over $100,000 over the last, I think, 4 or 5 years. Kaiser Permanente has had grants that have looked at wellness spaces in schools. We looked at how it meets board goals, what are the targeted outcomes, and what metrics we have. We actually had a rich discussion and looked at, added to the metrics that we have included in the wellness space that Kaiser Permanente is sponsored. Has the space been maintained over time after, let's say it was put together in 2020? Is it now stuffed with storage because the school ran out of storage and had no other choice? So those are things we're going to be looking at. Next slide. Health coaching, major issue. Again, the board goals that it meets looks at helping people live healthier lifestyles. Again, that shift to the left, and member education. Again, we're looking at health coaching is not something in and of itself. It's a tool that can be used for various interventions. And you'll see as we talk about pre-diabetes where helping plays out. Next slide. So these are the preventing diabetes. Kaiser Permanente uses a platform called OMADA, and MODA is developing its own program called Pre-D. There are similarities and differences, but in general, both of them are heavily using health coaching to work with people. They have broad outreach in terms of offering these interventions. Then it's a question of what percentage actually engage. So I think that's the biggest challenge at this point. As we've looked at, we have early data. The Kaiser group of I believe it was a little over 100 people who've been in their program for 26 weeks have averaged 3.1% weight loss. The problem or the issue is going to be, and we're going to find out more information, what percentage of that group actually had that 5+% of weight loss. That's probably looks to be kind of that magic place. So we'll continue to look at refined metrics. These are both new programs. It's not like we're saying yay or nay on them, but we're looking at them with the idea of trying to help refine the measuring process so that we are able to answer the targeted outcomes. In fact, are we preventing and delaying type 2 diabetes? Okay, next slide. BH stands for Behavioral Health 360. It's an intervention that MODA put in place with the idea of assisting their members who are having difficulty obtaining appointments for behavioral health. They also added in several additional PPO networks for behavioral health. The goal is both to provide high quality mental behavioral health services, that it's a good fit for the member from social, racial, language standpoint, and then to collect data on treatment outcomes. It's new, it's building, and again, we helped refine the metrics around which we'll see how this program goes. Next slide. And this is the last slide. This was care management, PCP, primary care physician or practitioner 360. CCM stands for, help me folks, coordinated care model. Thank you. And MODA 360. MODA 360 is the enhanced application of when members call or connect with MODA, of being able to look at their dashboard to more than just answer the simple question that they may have, but actually to use it as an opportunity to look for quality issues, whether or not people are having their all of their prevention efforts addressed and the like. So the PCP 360, from my view, is a pretty amazing success. The people who were at higher utilization are now significantly present in this enhanced primary care model, where people receive care management more than just dealing with the problem of the day. And I'm not giving the issue really for the board adequate explanation, but it would take 10 or 15 minutes, which we don't have. The importance here, though, is we, over the last 4 years, we shifted from one coordinated care model to one that actually incented low-risk people to come into it. Now we are incenting the high utilizers, where the intervention will again help manage and control the utilization and the chronic diseases with better outcomes. And the success of it has been shown when we look at every single clinical quality measure, like women receiving mammograms or diabetes control or hypertension control. All of those clinical targets that we look at, they're doing better in the people who are in the PCP 360 or coordinated care model as compared to people who are not. So again, tremendous success in this effort. I think we're at a point now where 75% of the membership is in the PCP 360. I think that's the last slide. Did I have anything else, Rose?
No, that was the last slide.
That's the last one. Okay.
Yep.
So again, that was the whirlwind. My CL colleagues, any additional comment that you'd like to make? All right. So we are a couple minutes over. I have 2:29. We're due for a break. We will reconvene at 2:39 and get an update from the Health Equity Work Group. Thank you.
Hey, Tom. Georgianne is ill and won't be able to do her update, so we can move that to next month. That'll be 10 minutes. I think we'll get back.
Thank you.
Yeah.
Okay, I have it at 2:29, so I think it is time to jump back in. Ali just told me that our 2:45 item advisory group report is going to be put off a month because of illness from Georgianne. So we'll go ahead and move forward with the health equity work group update. And Christy, you're on.
Great. Thanks so much, Tom. Hello, everybody. Such a pleasure to be here with you today. And would love to open this up also, as always, just if you have questions, and would love to have discussion around this. So today I'm going to share with you just a piece of what the Health Equity Work Group has been up to over the past couple months. I'll just share with you first some of our status updates. We're going to talk about some of the benefit coverage considerations that we have been a part of, and then talk a little bit about future direction and priorities. So next slide. Great. So just to provide a snapshot, I won't read these over step by step, but I just wanted to show, as a work group, we have a lot of things that come our way. And one of the key considerations that comes our way also is through member feedback. It's member feedback, it's the board, and then also OHA staff. And so a lot of that does inform the work that we are doing. You can see that we've completed, so we do have a charter that our group works under. We did do an update to that charter this year, and had that reviewed by a few of the board members that do participate in giving us guidance in our meetings. We also do some benefit vendor assessment follow-ups for PEB. And so we also have done that, and we have those on an ongoing basis where we have identified some of the opportunities from the carriers in moving forward a more diverse provider network, making sure that we are meeting accessibility guidelines and different components that came out of that review. We have provided last year some high level considerations to GLP-1 treatments. I'm going to share some of that with you today. And we continue to be part of the CIAO work group and being able to have continued discussions and bringing health equity and just some of those considerations to those conversations within that work group. We also have our health equity screening tool, which is a tool that we use to have consistency when we are looking at different programs, resources, and benefits. It's a tool that helps us apply to what we are looking at for considerations, and again, provides us some consistency and is a great starting point for our discussion and doing research, and then kind of provoking a deeper dive so that we are able to provide those considerations to each of the boards with the decision making. And then lastly, we have our health equity. So we also, OHA staff this year had asked for a condensed kind of health equity screening tool for legislative bill season. And so we had our inaugural season with that tool we put together in conjunction with the Health Equity Work Group. And we've also just recently made updates since it has been used through one legislative cycle. A couple things we have in progress you can see here. So again, those health equity considerations with the CIAO work groups for GLP-1 for obesity treatment and also for doula benefits. We are right now working on compiling some benchmarking data that's going to be part of the October board retreat. And then we are starting some work on those dental preventative care health equity metrics as well. Next slide, please. Okay, so now I'm going to dive into some of these benefit coverage considerations. So first, the doula coverage and the doula benefits. So our the health equity work group has been participating in the doula work group. And so as we did our deeper dive in order to really kind of call out some of the considerations. So doula benefit coverage it's solving for an equity issue. And so, but even within the benefit, there are things that as the coverage is designed, we want to make sure that it's an equitable benefit that's being designed and offered. And so I know in some of the previous conversations, noticing though that the network for doulas, as was previously reported, there's about 230 doulas, and I believe that was from a July count that are certified and able to provide doula services through OHP. So we want to make sure that we also are not designing a benefit that's going to pull away from that network of doulas. We've been trying to kind of also ascertain if there's enough doulas in the network, what's the demand right now versus what's available for doulas as far as providing the service. So providing just some of those network considerations. The next piece was in plan design. And so really looking at the literature and what other states have in place. And we really using the Medicaid population is where a lot of the literature is, just because it is still so new in private and commercial plans. But really knowing that the literature shows, the best type of plan design is going to be for the full spectrum, prenatal, during birth, labor, and then postpartum. And up to 1 year post-birth is really important. But again, that's a lot of times actually where a lot of support is needed. It helps with postpartum depression and also with initiation of breastfeeding is also, there's a good big component there where doulas support breastfeeding initiation. And then also considering what the benefit cost design is. And then looking at the doula reimbursement for doulas. So looking at what the reimbursement rate currently is through OHP, one thing that's interesting here is just recognizing that Oregon Medicaid has a really high reimbursement when we look at across all of the states offering doula benefit coverage. But they do have one of the lowest visit counts. So the 2 prenatal, the 2 postpartum, and then during the labor and delivery is actually one of the lowest visit counts among all of the states. And so just considering what that looks like for the doulas, also taking into consideration for a doula to get certified, to finish the training and the curriculum, to get set up with the national provider identification number in order to be able to be part of being reimbursed. And then there's also a lot of literature that shows that doulas actually spend many, many more hours with their patients, answering texts, taking phone calls, than is actually what is typically reimbursed. Moving on to reporting, we also in the doula coverage, just recognizing that we really want to make sure that in doula reporting that there is that the real D and SOGI data being captured. So race, ethnicity, language, disability, sexual orientation, gender identity, so that we can start to monitor to see if there are any unintended consequences, and if we are making sure that the benefit is being used equitably across different populations. Wanting to really make sure, doulas, a big piece of the doula is referring the birthing person to additional care. So, again, like the doula is obviously not the one that's going to be providing any type of mental health care to the birthing person. But if they're noticing that there might be a need there, then they're a trusted person who's going to be able to connect that birthing person to the behavioral health resource that could be available, whether it's in a community benefit, whether it's part of the benefit ecosystem of OEBB, but really referring. And so having some mechanism of tracking those referrals is really important. And then reporting on the doulas. Is there a way for us to integrate notes, or at least knowing that there was a doula involved as part of that that birthing person's care, so that we can also track those outcomes and the impact of a doula versus not having a doula. And then lastly, just communication and really making sure, I think some of the statistics, doula care right now is very underutilized. And so just making sure that the communications are accessible for everybody, that it is being communicated, that there's some support in connecting members with the doula services available, and then really having a supportive and collaborative relationship with the doula and the medical care team. All right, let's go to the next slide. And so now I'm going to switch to the GLP-1 CL work group that we also have been involved in. And one caveat I just want to say here is that the information I'm going to share with you is regarding health equity research with GLP-1 treatments with type 2 diabetes. Because GLP-1 treatments for obesity are so new, there is really a lack of research as far as equity considerations specific with obesity. So I just wanted to make sure that I'm being super clear about that a lot of our research is from GLP-1 treatments for patients with type 2 diabetes. But it still is interesting, and I think it can inform our considerations as we start to look at these different coverage and plan design considerations. So there are inequities, and I think as Dr. Twang said earlier, if you look at the prevalence of obesity in different populations, and then you look at the prescribing of GLP-1 treatments in different populations, they're not equitable. And so that is the case in type 2 diabetes. And so we are seeing that the treatments are different. And one that is specifically, I think, interesting is with the Veterans Health Administration, because this research took out the socioeconomic impact. There was no cost associated to it, but there still was found to be inequities in between the prevalence of people having type 2 diabetes and then in the prescribing of the GLP-1 treatment. If we move to the next slide, so then as a work group, we came up then with our summary of what our health equity considerations were. And so kind of into 3 different buckets here. So as a treatment perspective, again, just recognizing the prevalence does not always match up to what is being prescribed. And that can be due to multiple factors. So there can be some cost impact, again, depending on the plan design and if there's a high deductible health plan in place. There can be some prescriber bias. Again, we all inherently have these unconscious biases, and they do come into play here. And then the other thing in the treatment perspective, and I believe this was brought up earlier, was just that concern of using BMI alone to determine eligibility. The American Medical Association did just come out with a position statement on this and just saying, it is BMI is still, again, population health is good to track trends and to look at large populations, but sometimes when you're looking at an individual and making treatment decisions, then using some other metrics is important. Secondly, here is that plan design impact on the member. So just recognizing, again, a higher deductible health plan is going to impact a member differently than a different type of cost share plan. And that also some populations may have less options for receiving GLP-1 treatments. Lastly, then the integrating of the lifestyle behavior change piece. And so this is a big equity component. And I think, you know, recognizing that the social determinants of health come into play here, access to food, access physical activity, and again, thinking about how our lifestyles are situated. And, you know, if some folks have, if you're caring for an elder parent or small children at home and you have a full-time job and you're, you know, maybe a single parent. I mean, there's lots of different lifestyle factors that kind of come into play here, and that can really be barriers to making changes. And then lastly, there's been a lot of research around culturally sensitive diets and interventions, just making sure that recognizing that some interventions, diet related, are not culturally sensitive. And so wanting to take that into consideration when the lifestyle behavior change programs are being considered. So I'm just going to pause for a minute. It seems like I don't see any questions. Okay. Awesome. Let's move to the next slide, please. And next. Okay, so kind of what's coming in our future that we're working on. And so we do have the review of Weight Watchers is coming up, and then more broadly looking at some, again, those cardiometabolic treatments and benefits. I already talked a little about the dental preventative care and treatment. We have that benchmarking that we're working on at the October board meeting. Something we've had also is some health equity considerations for excluded coverage services and additional cost tiers. That's kind of been on our radar. It's on our list. And so that's something we'll be looking at in the future. Again, these lifestyle modification programs that, depending on what, you know, what recommendations are brought forward for GLP-1 treatment coverage for obesity, then also will be starting to look a little bit deeper at those lifestyle behavior change programs, more from an equity perspective. And then the last two pieces here is that reviewing the fertility services and benefits is also in the future, sooner rather than later. And then we also have that House bill that was regarding reproductive health and gender affirming care as well. So we are going to be diving into that as well. All right, I think that is my last slide. Any questions about anything or?
I'm just going to share my perspective, Christy, that
Great.
over the last 2 years, you know, before the last 2 years, we just didn't explicitly look at what we're doing through a health equity lens. And there's been more than one ahas as we have. And it's very helpful to have an organized approach to it, number one. And two, I'm really glad we're doing it. It's we are going to be meeting the needs of our total population much better by what we're doing.
Thanks, Tom. I agree. I think this is such important work, and it really is looking at the individual and their lived experience, and doing our best to have programs and resources and benefits that meets everybody's needs.
Yeah. So thank you. Great work. Keep it up. Mm-hmm. Got a lot more to do.
We have a lot of work. So yes.
Yeah, we've got a lot of work. Okay. We're moving on now to Innovation Work Group update. Jeff.
Yes, I've kind of been absent much of the last month, so I've asked Margaret if she could give us an update on what's been going on this summer.
Super.
Yeah, absolutely. I am happy to do that. Can everyone hear me okay?
Yep.
Great. And Jeff, certainly feel free to chime in with anything you want to add. But just to sort of give the lay of the land of where the innovation work group has been and what's new. First to note, the work group did pause public meetings over the summer. So the last public work group meeting was actually held on May 16th. The work group will next convene the afternoon of September 19th. So over the summer, there has been a lot of staff level work in progress. We haven't been having public meetings, but we have been regularly meeting as a core team internally to do some strategy and planning. In particular, work continues on the Center of Excellence project. Now, this is the project we're working on to develop options for a Center of Excellence program for hip and knee replacement surgeries. And I think as we mentioned to the board last spring, this work continues, but we are on a bit of an adjusted timeline, looking at a longer runway to build and implement the program. And what this would mean is that the program, we would have sort of take an initial focus on early identification of members who may need these services, and also communication strategies to provide both members as well as providers with information about quality and information to help support decision making around the care they seek and where they seek this knee and hip replacement surgeries. We're also considering under that framework that sort of additional strategies that would go to plan design provisions or incentives would follow on a bit of a longer runway, would sort of follow that rollout of communication and member education initiatives. In terms of data analysis, we are working to get updated hospital and ambulatory surgery quality data related to these procedures, and that includes both related to outcomes and complications. That's expected for the work group to be ready to review that information in late 2023, so we're looking toward the end of this year. And again, that data is going to come from Oregon's All Payer All Claims database, APAC, which includes the overwhelming majority of claims for services in Oregon. So it's going to be a pretty robust data set on the vast majority of surgeries performed at Oregon facilities. And we want to use that larger set of data in order to really produce the next iteration of our facility quality analysis. I do want to note we are looking at options for potentially looking at this approach for sharing quality information and decision support to members for other procedures as well. In particular, spine surgeries have also been considered as something we may be able to pursue and look at this data for as well, and this similar approach. We are continuing to engage with carriers around approaches to identify members early. To engage and educate members in their options, and that includes both surgical as well as non-surgical options. And we're looking at strategies around provider education as well, particularly how to best share and support primary care providers and physical therapists with information on surgical quality. Those are the providers that are likely seeing, members early on in their care journey and are, well positioned to engage with members around surgical outcomes, complications, quality, and choosing where to go if they do need a higher level of care. We are scheduled to present an overview of the project to the Oregon Association of Orthopedic Surgeons later this month. The purpose of that is to just share with them a little information about what we're working on, give a description of the project, and we want to seek their input and questions, as well as we will likely have a few key questions for them we'll ask them to react to. That's all part of our provider engagement strategy. And we'll continue to provide progress updates to the boards, both the PEB and OEBB board, again, through the Innovation Work Group. This is a joint initiative. We'll continue to share progress updates throughout the fall, and that will include any potential recommendations we may want the boards to consider for the next renewal. We would certainly have those prepared by year's end. Are there any questions about the Centers of Excellence project? I have a few more updates about other work on the IW work plan, but I'll pause here in case anyone has any questions. Okay. Hearing none, just to share a little more about the other things on the Innovation Work Group's work plan. We are scheduled to look at some updated review of level of payment data. This involves comparing both PEB and OEB payments across various service categories, comparing them to Medicare as a benchmark. You know, if you'll recall, we know for a large proportion of our hospital services, because they are capped at 200% of Medicare, we can sort of look at, we track sort of where we are in terms of paying for those hospitals in line with the statute. Kind of leads to a lot of questions regarding for other types of care that are not capped statutorily, how do our rates compare and how do we benchmark those? So a lot of that level of payment data review is focused around getting a better understanding of what our payment levels look like compared to Medicare as what we're at this point considering to be the best available benchmark. Along with that, we also are scheduled to look at our annual compliance review of the hospital payment cap. That'll involve reviewing payments that occurred in 2022 to ensure that they didn't exceed 200% for those facilities that are under the cap. We also anticipate this fall we'll have a couple of updates from some of the other OHA programs, including the Cost Growth Target Program, as well as we anticipate the Value-Based Payment Compact Work Group is going to present some recommendations around primary care value-based payment models. We have a couple of other topics in the queue related to looking at some cost and utilization analysis around sites of care. This will look at key service areas and also different sites of care with an eye toward, you know, options for site neutral payment policy development. And then we also are tentatively expecting later in the year to look at identifying some recommended options for behavioral health network adequacy standards that we could then engage with carriers on in terms of getting some quantitative ways to regularly examine how adequate our behavioral health network access is relative to a specific measure. So that's sort of a lot I've listed out in terms of topics in the queue. Of course, the Centers of Excellence project continues to be the big one, but we do have, as I noted, those other bodies of work in process as well.
Well, thank you, Margaret.
Yeah, you're welcome.
You got a lot better report from Margaret than I would have given.
She is organized.
She is, and it just goes to show you that staff and consultants have been busy while we've been on summer break.
That's the truth. That's the truth. Okay. Thank you, Margaret.
Thank you.
Okay. Or second to the last item is the director's update and board membership changes. Ali.
Thank you, Tom. Please bear with me with my sniffles and my voice. My family's been battling the COVID virus, and my voice is probably even quieter than normal. So I did want to provide an update on House Bill 3383. This was enacted during this last 2023 legislative session, and it changes the current composition of the OEBB board. It does this by removing one of the board positions with expertise in health policy or risk management and adding one board member position who is employed as a classified staff at a public school or an educational district. So the bill is supported by the Oregon School Employees Association and applies to the first open health policy position on the board. So while we're grateful to add a classified staff member to the board, and look forward to doing that soon. Losing a health policy expert position looks a gap that we will look to fill, whether it's through staff, Mercer, or even a legislative solution at some point. We did consult with our DOJ attorneys to explore whether there was any flexibility to add new board positions. But they confirmed that the only pathway to add new positions is via the House Bill 2279 legislation, which allowed for local government participation in PEB or OEB. And you might remember this directs new board positions be added for every 25,000 new local government covered lives. So while we're getting a lot of interest from local governments, that's a lot of lives to take in. So we're left with next steps basically. And Jeff Brown's second 4-year term with OEB is ending, and his last meeting scheduled to be the October retreat. And hopefully we'll have the new board member confirmed by the Senate in November. It sounds like there's a good chance that's going to happen. So we'll get that new board member onboarded. As Tom mentioned earlier, there will be some opportunities for board members to participate on CIAO and the Innovation Work Group, and even serve in leadership positions on those work groups. If you have any interest in either, I would love to speak to you further. We can definitely work with your schedule, and I can promise you that it will be well worth your time. And you can even speak with other CIAO members or Innovation Work Group members about what to expect. But are there any questions regarding the implementation of this legislation or participation on CIAO and or the Innovation Work Group?
Ali,
We have one. Yeah.
Go ahead. Take the other person first. There's a hand up.
Yeah, please go ahead, Susan.
Susan.
Thanks, Tom and Ali. I just wanted to clarify that OSCA's legislative concept was to add a seat for a classified employee on all boards and commissions, because classified do not have any seats before House Bill 3383. And our goal was to uplift and raise the voices of classified workers. There was no advice from OSCA on actual removal of any policy advisors. So I just wanted to clear that up.
Okay. Thank you. I appreciate the clarification, Susan. And Tom, did you have a question?
Yeah, I actually have a request. You know, as we look to rebuild CIAO, we have not had a woman on CIAO for years. I'm trying to think back when we had one, and I don't remember. So, but that's because yeah, well, it just shows that was before my time. So yeah, my memory is it would be very, very helpful to have that a perspective. Obviously, we get support from our consultants and our health plans, but it would be, I think it would be very helpful, not just nice, it would be very helpful to have a woman board member on CIAO. Sue.
Thank you, Tom. Having the opportunity to serve with you on the health equity work with PEB, I would appreciate being considered for a seat at CIAO.
I'd love it. That'd be great.
Yes, thank you.
I should ask. Do you want to chair it? No, I'm on.
Get greedy.
You know, yeah, I won't. I'll shut up. Thank you. That's a wonderful.
Yeah,
that'll be a wonderful addition.
Tom's on the tail end of the doubleheader here.
Yeah.
I did have a couple other things to add, Tom.
Yes, please.
I just want to mention the fact that we'll be planning an optional post-meeting get-together after the October in-person retreat to honor Jeff and the tremendous contributions he's brought to OEB. I mean, really, since the inception of OEB versus a consultant, and then after retiring, he felt strongly enough about OEB to participate as a board member for 8 years. And I personally can't begin to express how much Jeff will be missed on this board and what he's meant to many of the staff who've worked with Jeff over the years. And we've been through some really challenging times together, and the fact that this is in this last legislative session, there was not one bill introduced that would allow for districts to leave OEB or eliminate OEB. This was first, so I believe that's really a byproduct of the work that Jeff put into this. He's always looked out for members from every part of the state, and that's really strengthened OEB's credibility around the state. So from my Jeff's ability to think outside the box and creative solutions to problems that on the surface seem impossible has really been a privilege for me to watch and be a part of. And lastly, I think every time I hear the Masters golf tournament jingle, I don't think about the Masters on CBS. I think about just, we've all heard Jeff's phone ring during board meetings. So I think I'll smile every time I hear that jingle come up on CBS. So thank you, Jeff, and we'll find time to thank you in person next month. So appreciate it.
Thank you, Ollie.
Yeah. That's all I've got, Tom. Thank you.
Great. Thank you. Okay, Rose, do we have any public comment?
No public comment.
Okay. With that, then, I'm going to call a close for the September 5th, 2023 OEB meeting in honor of Jeff Brown.
Thank you.